So I thought I would do a couple of talks on drugs and devices. It occurred to me some time ago that there are a whole bunch of new drugs that have just been released within the last 5 to 10 years, as well as new devices that are used to deliver some of those. So today we will focus mostly on drugs. There'll be some mention of devices because you can't separate them completely. And then I'll prepare a second talk where we'll talk mostly about devices rather than about drugs. So our objectives here are to compare beta agonists and anticholinergics, to compare short-acting and long-acting bronchodilators, to discuss the role of inhaled corticosteroids in asthma and COPD, to discuss the roles of inhaled mucokinetic agents. No, Mucovis does not work. We'll come back to that. Antimicrobials and vasodilators. How's that?
Nothing has changed?
Nothing has changed. And to describe the roles of inhaled opioids, Lasix, heparin, and tranexamic acid. And we'll actually even touch on a few other things along the way that get used infrequently. And there may be others, too, that I'm not even aware of.
See, we've done, I think, 4 patients with tranexamic acid.
Yeah, so I'll touch on that towards the end. So as far as inhaled drugs, there are a lot of things we could put on the list: bronchodilators, steroids, mucokinetic agents, antimicrobials, vasodilators, opioids, Lasix, heparin, tranexamic acid, insulin, and there may be others as well. One other one is TPA, which I'll mention a little bit towards the end of my talk. And we won't say anything about aerosolized heparin. Yeah, so those of you who have been around for a while, or maybe even those of you who haven't been around that long, can relate to this. So the idea sort of is from some of our physician colleagues that we can sort of dump anything into the nebulizer and administer to the patient, and if one drug might help, well, let's put 2 or 3 in and let's just see what will happen. And sometimes what happens is not necessarily good for our patient. So inhaled bronchodilators. We'll spend a lot of time talking about inhaled bronchodilators. Inhaled bronchodilators are of 2 classes. They are the beta agonist or the anticholinergics. The anticholinergics now are typically referred to as muscarinic antagonists. That's probably a better term than anticholinergic. The beta agonist can be short-acting beta agonist or long-acting beta agonist, SABAs or LABAs. The LABAs have become increasingly important in their use over the last 10 to 15 years, and there have been a number of them introduced to the market, some introduced to the market just within the last couple of years. And some of these now have a very long duration of action, meaning that they only need to be taken once a day by the patient. As far as the muscarinic antagonists, these can be short-acting, the SAMAs, or they can be long-acting, the LAMAs. And then the other thing, as we will see, there are now all kinds of combinations of these drugs in the same formulary. So there are SABA, LAMA combinations, and so forth, and we'll look at some of those as we go through the presentation. The naturally occurring catecholamines are epinephrine and norepinephrine, which arrive from the adrenal medulla. And there are derivatives of these, or actually these drugs and their derivatives that are used therapeutically. So if we look at the respiratory side, we can begin with epinephrine, which has beta-1, beta-2, and alpha effects. So beta-1 effects primarily result in tachycardia, beta-2 effects on bronchodilation, alpha effects on vasoconstriction. So if we are interested in a drug primarily for its respiratory effects, then we want to have as much beta-2 action as possible and very little or no beta-1 or alpha effect. So we could administer epinephrine inhaled as a bronchodilator. However, we will get with that not only the beta-2 effects for bronchodilation, but the beta-1 effects and the alpha effects. By the way, and I don't have this in the presentation, we do use, as you know, aerosolized epinephrine sometimes for its alpha effects, its vasoconstricting effects, in the setting of stridor, for example, upper airway swelling. I won't get into that anymore in the presentation this morning. Then back in probably the 1960s was introduced Isoprel, which got rid of the alpha effects, but kept the beta-1 effect as well as the beta-2 effect. And Isoprel is a very good bronchodilator. The only problem is that it also causes a lot of tachycardia. I'm looking around the room first,
It makes you jump
and
all
Bob
over the
will
place.
remember when we administer a lot of aerosolized Isoprel, patients would become very tachycardic. They would also develop a lot of tremor as a side effect of the
Tremor,
of the Isoprel.
anxiety.
Correct. And we're going to list some of those side effects here in a minute. And then from about, I don't remember when Bronchosol isoethylene came out, probably around 1980, I would guess.
I
Maybe
was gonna say,
that
was
in the late
Alucant, I think.
70s.
Oh, I remember
Yes.
that.
In the
So-
70s, I think.
So Bronchosol is isoethylene. So these are all short-acting beta agonists. So now we get rid of the beta-1 effect. And the first one of those was Bronchosol isoethylene that came out 35 or 40 years ago. And then Alupent, metoprolol, came out probably in the 1980s. And I remember when we got rid of all the Bronchosol, which we used to keep in the refrigerator in the respiratory care department. We threw it all away, replaced it all with Alupent, which was a better beta-2 and more selective beta-2 agent. And then albuterol became available probably in the early 1990s, I'm going to guess, something around that time. And that is what we use primarily today as a short-acting beta-2 agonist. There is also levalbuterol that is available. And we'll talk more about levalbuterol or Xopenex in a few minutes, and I'll try to explain to you why it is that that's not as good of a drug as maybe it was once thought that it was. And now today we have a number of long-acting beta-2 agonists. The first one that became available was salmeterol. Probably became available 15 years ago or so. Now there are a number, formoterol actually came out around the same time. There are actually now other long-acting beta-2 agonists. And some of these, as we'll see in a few minutes, are very ultra-long-acting beta-2 agonists, meaning that they only need to be taken once a day. And I should also point out that the short-acting beta-2s are reliever medications, so they have a rapid onset of action. The long-acting beta-2s are controller medications that are not used as reliever medications.
So just a question, and I've
Yeah.
always, the peak effect of the long-acting is not as great as the peak effect of the short-acting.
I don't know if I don't know about the peak effect. The duration
The
effect
duration
is
is
much
different,
longer.
right.
I'm not sure how the peak effect compares.
Because I always thought that was the reason why it couldn't be used as a reliever.
Well, it has to do with onset of action. So salmeterol, for example, has a short onset of action, whereas formoterol has a more rapid onset of action. So formoterol has been used by some as a reliever because it has a rapid onset of action and a long duration of action. So I think the biggest reason why salmeterol is not used as a reliever is because of the slow onset of action, more so than the peak effect. I don't know how the peak effects compare, to tell you the truth. So if we look at the cardiac side of the slide, so the two drugs there are norepinephrine, or what we know as Levophed, which is administered for its alpha and beta-2 effects, so it increases blood pressure, and phenylephrine or eosinophil, which is administered primarily for its alpha effects to increase blood pressure. But we're going to obviously today focus more on the respiratory drugs. So the primary pulmonary effect of the beta agonist is bronchodilation, relaxation of bronchial smooth muscle. They also have other effects such as inhibiting mast cell mediator release, so that can be helpful as far as allergy, inhibiting airway edema and plasma exudation, increasing mucociliary clearance, and increasing mucus secretion. These are pharmacologic effects that are not clinically important. So as I will come back to in a few minutes, we should not be administering albuterol to try to improve airway clearance. So although these are pharmacologic effects, the clinical benefit is negligible. They also decrease parasympathetic transmission, and they may reduce cough. There are also a number of systemic effects of beta agonists. So these sometimes we think of as side effects, but they are sometimes desirable effects, as we'll point out. So the big one that we all think about is the cardiovascular effects of tachycardia and palpation. There are central nervous system effects such as headache and insomnia and nervousness, as Bob pointed out, we used to see with Isoprel, for example. The GI tract, nausea and vomiting, musculoskeletal tremor. Some of the beta-2 agents are notorious for producing tremor. Terbutaline, for example, has been not even used as a bronchodilator very much anymore because of its tremor and tachycardia. And there are biochemical effects such as reducing serum potassium and glucose levels, and sometimes this is used therapeutically. So there is a literature around using high-dose inhaled albuterol in patients who have hyperkalemic renal failure. And I know that a few years ago there was a patient in the MICU who they were using high-dose albuterol.
How high?
To lower.
How high is high?
Like putting a straight albuterol solution into the nebulizer and administering it to the patient. So it's, it's a temporizing effect until the patient can get dialyzed. But there is actually a literature around this, and some of the literature is 20, 30 years old, about using high-dose albuterol to decrease potassium in patients with hyperkalemia related to renal failure. So that's something you may come across. And then beta agonists have effects on uterine relaxation. There was a time, and those of you like Danielle and Kathleen can help me out here, there was a time that terbutaline was used to suppress labor, but I don't think so much anymore. Do you know?
They still do in some cases.
Because from my sense is that mag sulfate is used
They use
more commonly.
magnesium, but if they're still struggling, then they'll throw some turb on board too.
So that's obviously not inhaled. That's sub-Q, I think, typically. You know, is it? I think it's sub-Q injection.
I think it's an injection, and then the mag is a drip.
Yeah. So it's interesting that some of these things that we might think about as side effects of beta agonists can sometimes be used for beneficial effects. So what about Sopanex? So what about single isomer beta agonist, which is what Sopanex is, or levalbuterol? So there are mirror image enantiometers which rotate light in different directions. So that means that a molecule will rotate light either to the right, dextrorotary, or to the left, levorotary. These are called the S and the R enantiometers of the molecule. So albuterol, racemic epinephrine are half R and half S. As it turns out, the pharmacologic effects of the beta agonists are due to the R isomer. That's actually is this one. You can see here's the molecule, which is, these are mirror images of one another. So when Sopanex came out, levalbuterol came out, probably 15 years ago now, the claim from the manufacturer was that since it is a single isomer, it gets rid of the inactive isomer, and in fact the manufacturer at one point claimed that there are harmful effects related to the S isomer. So if we give racemic albuterol, half of it is effective, the other half is not effective, and it may be harmful. Well, it turns out the S isomer is ineffective, but it is not harmful. And in fact, the evidence now supports that the dose-related increases in heart rate and tremor are identical for racemic albuterol that we use every day and for levalbuterol or Zopinex. So the evidence really doesn't support that Zopinex, which is all of the R isomer, all of the good stuff, the evidence does not support that that is better than racemic albuterol. And I can recall that when Zopinex first came out, there was pressure here, a lot of pressure from some physicians to get it on the formulary. And the pharmacy was resistant to that. And they were resistant primarily because it was really expensive, truth be told. But it turns out they're probably right, because really the evidence doesn't support that there is a benefit for Zopinex over racemic albuterol. Do any of you know, those of you who might have per diem jobs other places, is Zopinex still used out in the community?
I just used one yesterday here.
Yeah.
Here?
Yeah.
Here? In this community?
Yeah,
They have it in the PICU.
So it's on the formulary now?
It is.
Yes.
At my per diem hospital, it's usually the patient's dosages that they provide themselves.
Yeah, so there is a whole body of literature now which supports that Zopinex, on a dose-by-dose basis, Zopinex and racemic albuterol are equivalent. So why pay the extra money for Zopinex? Yeah, my sense was that that even out in the community where it had been used a lot in the past, that they're really getting away from using it. But
Do you know the cost difference? Just out of curiosity?
yeah, I do not know the cost difference. It was substantial at one point, but yeah, I think at one point it was several-fold difference in cost. Albuterol is dirt cheap.
Exactly.
So maybe take-home message: there's no benefit of Zopinex over regular old albuterol, and there have been a number of studies now that reported that. So in guidelines, for example, in guidelines for management of asthma, single isomer agents like Zopinex are not recommended. So the beta agonists then can either be short-acting agents, which means that the action lasts a few hours, or long-acting agents, which means that the action is over 12 or in some cases 24 hours. So the short-acting beta agonist that we all know is albuterol or perhaps Zopinex, which we can administer by nebulizer, metered-dose inhaler, or dry powder inhaler. So the Respiclick is a dry powder inhaler for administration of albuterol. ProAir, I think, is the brand name. And then there are now a number of single-agent, long-acting beta agonists. So the first ones to come onto the market were salmeterol and formoterol, and there are now additional ones that have come onto the market, I think just within the last 5 years. And the newer ones that have come onto the market, which are administered in one case by dry powder inhaler and in another case by the Respimat device, are ultra-long-acting bronchodilators. The duration of action is up to 24 hours, and they are administered once a day only. I'll also interject here that a few years ago there were concerns about long-acting beta agonists, and there were concerns that the use of long-acting beta agonists increased mortality in patients with asthma, and in fact for a while the FDA required a black box warning on the label about the potential for increased risk of death with long-acting beta agonists. Turns out not a problem, and I think about 2 years ago the FDA took the black box warning off of the long-acting beta agonist, and that has led to additional ones coming onto the market. So, albuterol for everybody.
Used to be that way.
Cures everything except stupidity. Instead of using science, just order albuterol. Or Zopanex. So what about the routine use of bronchodilators to aid airway clearance? So we said that some of the pharmacologic effects of beta agonist is that it improves mucociliary activity, but the clinical effects of that are trivial. And in fact, the AARC clinical practice guidelines published a couple of years ago recommend that beta agonists should not be used as a way of aiding airway clearance. Clinically not important. So what about administering bronchodilators to every mechanically ventilated patient? I can recall having physician colleagues and friends tell me, why not? Albuterol is cheap, what's it going to hurt? Well, there are probably lots of things that it could hurt. One is the outcome of the patient. The ARDSNet studied this, published a paper in the Blue Journal back in 2011, where they looked at the use of beta agonist, albuterol, in mechanically ventilated patients with acute lung injury. So half of the patients got aerosolized saline, the other half of the patients got aerosolized albuterol. And if we look at ventilator-free days, less. That's bad for albuterol compared to placebo. If we look at death, greater, I think we'll agree, that's not good, in albuterol compared with placebo. So for sure, we need to be careful about using beta-2 agonists in patients with ARDS. If anything, the evidence shows that the outcomes of patients are worse. So albuterol for all, I would say absolutely not. And we should reserve albuterol for patients in whom there is a clear indication. Now let's change our discussion. Let's move from beta agonists to a discussion of anticholinergics. And the better term, and the term which is used more commonly now in the literature, is muscarinic antagonist. So if you see the term muscarinic antagonist, that refers to what many of us in this room probably have historically thought of as anticholinergics. So, the muscarinic antagonists affect receptors at either the synapse, the nerve synapse in the parasympathetic nervous system, or in the neuromuscular synapse. And as you can see, the muscarinic receptors are 3 types. So here's M1, M2, M3. The M3 receptor is the one that is most important as far as bronchodilation. So notice that this is airway smooth muscle. So if we block the M3 receptor site, that's what this little squiggly line here represents, blockade. So if we block that receptor, then that results in bronchodilation. So the first commercially available inhaled anticholinergic was ipratropium, what we all know as Atrovent. And interestingly enough, that only came onto the market not that long ago, 1987. I remember when Atrovent came onto the market, and that was exciting as a respiratory therapist, this new drug for inhalation, which is still pretty widely used. This is a short-acting agent, and it is non-selective. So Atrovent, ipratropium, blocks M1, M2, M2, and M3. So ideally, we would want it to be selective for M3, just as we want our beta agonist to be selective for beta 2. The long-acting agent, tiotropium or Spiriva, came onto the market about, I guess, 10 or 15 years ago. Hasn't been available for real long. This is a long-acting agent, so it blocks the receptor longer, and it blocks both M1 and M3. So Spiriva is also not very selective. As I already pointed out, antagonism of the M3 receptor is the one that is the most clinically relevant, and the newer agents, of which there have been a lot that have been introduced into the market over just the last couple of years, are selective for the M3 receptor. So being selective for the M3 receptor means that it's a better bronchodilator, and it also means that it tends to last longer duration of action. So some of the newer long-acting muscarinic antagonists are also ultra long-acting and have an effect for up to a day. So here are some of those. So these, I believe, are the ones that are now commercially available and are available for use in the United States. So the short-acting one, again, is Atrovent. That's the only short-acting one that I'm aware of, which can be used as either a dose inhaler or as a nebulizer solution. And now there are 4 different drugs and 5 different formulations of long-acting muscarinic antagonists. And some of these, as you can see, have a duration of up to a day. So they're administered once daily. There are others that are administered twice daily. The newest one that come onto the market as either a dry powder inhaler or as a special mesh nebulizer. We'll talk more about that on the next presentation on devices. But the newest agent is glycopyrrolate, which I find very interesting because we used to take glycopyrrolate injection and dump it into a nebulizer years ago and use it as an anticholinergic. I was at a meeting last summer, and some time ago, and one of the other speakers was talking about these various agents, and I'm sitting in the audience, and he says, now glycopyrrolate is a new drug cleared by the FDA as a long-acting muscarinic antagonist. But I heard that the MGH, they used to give it to patients back in the 1980s. And I'm sitting there thinking, yep, that's right. Used to be a favorite of David Canreck's, I believe, as I recall. So now there are a number of bronchodilator combinations that are commercially available. And there are combinations that are short-acting beta agonist and short-acting muscarinic antagonist. And there are others that are long-acting beta agonist and long-acting muscarinic antagonist. So the combo that is available in the United States is Combivent or Duonet, which is albuterol and ipratropium. There is another combination that is used in Europe. This one has not yet been cleared by the FDA to be used in the United States. So here we are limited to Combivent or Duonet, which are administered either Combivent by the Respimat inhaler or Duonet as a nebulizer solution. There are several, actually specifically 4 different LABA-LAMA combinations. These are available, none of them as a solution to go into a nebulizer, several of them as dry powder inhalers, one of them with the Respimat device. And notice that some of these, again, are ultra long-acting, a long-acting beta agonist, long-acting muscarinic antagonist, administered once a day. So that has a lot of convenience for patients. And by the way, in a minute, we'll talk about which ones might get used for asthma and which ones for COPD. Carla can correct me if I get it wrong.
That's all right.
I won't put you on the spot. So now let's move from bronchodilators to steroids. So let's talk about steroids, primarily inhaled steroids. So as is illustrated on this slide, the site of action of steroids is in the nucleus of the cell. So the steroid, first of all, has to go across the cell membrane into the cytoplasm, get transported into the nucleus, and then within the nucleus, the result of the steroid is that it affects the translation and transcription of DNA and protein synthesis. the whole point is that that takes time. So that's the reason why steroids do not have an immediate effect, typically. So the onset of action of steroids is slower than the onset of beta agonists because it takes a while for the steroid to get into the nucleus and to affect its response. Just a word about systemic corticosteroids. So there are short-acting, intermediate-acting, long-acting systemic corticosteroids. By systemic, either IV or oral. The short-acting ones are hydrocortisone. The intermediate-acting ones are prednisone, prednisolone, methylprednisolone. Long-acting one, dexamethasone. No, actually, not anything more about the systemic corticosteroids. Well, actually, one more thing about the systemic corticosteroids is that they have a lot of adverse effects. So on this slide is a long list of all of the different adverse effects of corticosteroids. Hence, the desire to avoid the use of systemic steroids to the effect possible, to the extent possible, because of all of the side effects associated with steroids. Hence, the interest in inhaled corticosteroids for lung disease. So the idea is that if we can administer the corticosteroid by inhalation, then we can avoid, perhaps, many of those side effects shown on the previous slide. There are a number of formulations that are currently available on the market. Fluticasone is probably fluticasone and budesonide, I suspect, are probably the two most commonly used ones. There are a couple that were recently taken off of the market. Asmacort triamcinolone was taken off of the market a few years ago, as was Aerosol. Essentially, when the FDA required that all metered-dose inhalers be HFA rather than CFC, some companies just took their drugs off the market rather than to make the transition. So then what about complications of inhaled corticosteroids? Well, you can appreciate that this list is a lot shorter than the list I showed a couple of slides ago for the side effects of systemic corticosteroids. The three big ones that we need to think about are pharyngeal thrush, the yeast infection in the upper airway, hoarseness, and we can address that by instructing our patients to rinse their upper airway after they use the inhaled steroids, and to use a spacer or a holding chamber. So next time when I talk about devices, we'll talk more about whether every patient who uses rescue albuterol needs a spacer. I'm just going to tell you I don't think they do, but every patient who uses an inhaled corticosteroid needs a spacer, needs a holding chamber to avoid these complications. Because now the drug, the aerosol that comes out of the metered-dose inhaler, ends up being deposited in the device rather than being deposited in the patient's upper airway. So it doesn't necessarily increase the amount of drug delivered to the lower respiratory tract if the patient has good technique, but it does decrease side effects. And then the other one we need to think about specifically in patients with COPD is it has been reported in several studies that patients with COPD who use inhaled corticosteroids are at greater risk for getting pneumonia. So as we will see in a few minutes, inhaled corticosteroids, although the primary drug used in asthma management, are used not as frequently for COPD because of this concern, and also because the LAMAs are very effective. More about that in a minute. So then this illustrates that if we administer the steroid by metered-dose inhaler, which is how it is most commonly administered, although some, like budesonide, can be administered by nebulizer, typically only a small amount, 50% or less, gets deposited in the lungs. I think 50% is really on the high side. I think most of the literature would support that maybe 10 to 20% of the drug actually makes it into the lungs. Well, where does the rest of it go? Well, it goes into the pharynx of the patient unless we use a spacer or valve holding chamber. And then that drug, which ends up in the pharynx, can be swallowed, gets into the GI tract, gets absorbed, goes through the liver. Some of it is inactivated in the liver, but some of it, perhaps a lot of it, can end up getting into the systemic circulation and potentially causing some of those systemic side effects that I showed on a previous slide. So then how do we get around this problem? Again, we use a spacer or valve holding chamber. We have our patients rinse their mouth after they use the drug, so that rather than this drug that gets swallowed, this drug that goes into the pharynx and gets swallowed, this drug gets trapped in the holding chamber. So it's not so much that the holding chamber increases the amount that gets into the lungs. It can if the patient has a bad technique. But more importantly, it decreases the amount that gets into the circulation. Now, there are also combinations of inhaled corticosteroids, as there are combinations of beta agonist and muscarinic antagonist. So there are combinations of inhaled corticosteroids and long-acting beta agonists. So that includes that includes Advair, which is available as a dry powder inhaler or a meter dose inhaler. Symbicort, which is available as a meter dose inhaler. So this is formoterol and budesonide. And there is also Dulera, which is an inhaled corticosteroid and long-acting beta agonist. The two that are used, I think, primarily in practice are Advair or Symbicort. And just from what I know about my own family, some of whom have asthma, whether you use Advair or you use Symbicort is determined by what your insurance company will cover. So I have some family members who use Advair because their insurance covers that, others who use Symbicort because that's what their insurance covers. And I don't think there's a lot of evidence that one is clearly superior to the other. And now there are also combinations of inhaled corticosteroid, long-acting beta agonist, and long-acting muscarinic antagonist, which is Trilogy, which came onto the market, I believe, only about a year or two ago. And this may have a role in the management of patients with severe COPD, as we will get to in a minute. So all kinds of combinations now, stuff that, when I went to respiratory school in 1973, we didn't have to think about any of these kinds of things. It was just Isoprel and Darnavac. We won't talk about Darnavac. So then how does all of this fit into patient management? So shown on this slide are the GINA, the Global Initiative for Asthma, I think is what that stands for. These are the GINA guidelines that were published about a year ago or so, showing how inhaled corticosteroids and short-acting beta agonists and long-acting muscarinic antagonists and so forth can be used in asthma management. And you can see that as a reliever all along the spectrum of disease, short-acting beta agonists are used, albuterol, essentially. And every patient with asthma should have an albuterol inhaler for this purpose. And then, as you can see, the focus on the management of asthma is inhaled corticosteroids, because asthma is an inflammatory disease and steroids are anti-inflammatory. So you can see that early on in the management of the disease and less severe forms of the disease, low-dose inhaled corticosteroids are used. As the disease is more severe, higher doses of inhaled corticosteroids are used, and long-acting beta agonists are used. So this is going to be Advair or Symbicort. You can also see, and this is relatively new, that with the more with more severe or less well-controlled asthma is probably the better term to use, tiotropium, long-acting muscarinic antagonist, might be added. So this is relatively new in the management of asthma. So up until about 5 years ago, tiotropium had an indication for COPD, but not for asthma. And now, long-acting muscarinic antagonists can also be used in the more severe, poorly controlled forms of asthma. So the focus is on inhaled corticosteroids for asthma management. But what about COPD? By the way, this is not me. This is another Hess. This is Mike Hess, who is a COPD educator in Michigan, as a respiratory therapist. But he actually wrote this very nice paper in Respiratory Care about a year ago as far as the gold guidelines for the management of COPD. So shown on this slide are the gold guidelines related to management of COPD, which is based upon symptoms. So few symptoms, a lot of symptoms, and then the number of exacerbations. So few exacerbations, a lot of exacerbations. But what I really want to point out here, so we're not going to talk a lot about asthma and COPD drug management, but what I want to point out here is that for COPD, the focus is on short-acting muscarinic antagonists and long-acting muscarinic antagonists. So you can see that even as far as reliever medications for COPD, short-acting muscarinic antagonists like Atrovent might be used as an alternative to albuterol. And then with increased severity of the disease, long-acting muscarinic antagonists are added, and it's only to the most severe disease, lots of exacerbations, lots of symptoms, where inhaled corticosteroids get added and may be added as triple therapy, that drug I showed a few slides ago. So the focus for COPD management is on muscarinic antagonists. Inhaled corticosteroids are reserved for more severe forms of the disease. And the reason for that primarily is that, first of all, asthma is primarily an inflammatory disease, COPD not so much so. And secondly, inhaled corticosteroids have a greater risk of pneumonia in patients with COPD. I thought I wasn't going to have enough material, and now I... Okay, let's talk a little bit about mucokinetic agents. Which, by the way, I like the term mucokinetic rather than mucolytic, because not all mucokinetic agents are mucolytics. So mucolytics actually break down mucus, and there are some agents that facilitate airway clearance that aren't necessarily mucolytics. So the first one on the list is Mucomyst, not effective. There are no guidelines that I know of that recommend the use of Mucomyst for airway clearance. Maybe for Tylenol overdose, but that's a different indication. So Mucomyst it's just not effective. I don't know of any support for its use in the literature. So it doesn't help, and it may cause side effects like bronchospasm.
So how about installation?
I'm not so sure that the literature even supports that, like instilling it down a bronchoscope or instilling it down the endotracheal tube or tracheostomy tube. It's probably more effective than by aerosolization, but there's not really a lot of literature.
I mean, in vitro,
So-
as you know, literature supports the fact that it
Correct,
works.
but if you look at those studies done way back in the 1960s and 70s, what they would take is on a petri dish, they would take a mucus plug that would be about this big, and then they would dump a whole bunch of Mucomyst on it, and it would dissolve away the mucus plug. But that's not what happens clinically. That's, it's probably not realistic. And certainly those, I never saw them blow aerosolized Mucomyst.
It doesn't work. Right. So you guys should not be administering Mucomyst? Can you get an order?
Can we have like an article to print out for them? Because I had some resident like argue with me on that the other week.
Yeah, we've had a few orders for Mucomyst nibs recently. I mean,
It
a lot.
pops up
Nurses,
now and then.
nurses can do those if they want them
Looking
done.
up to date.
You know, there's just no
Okay.
data. There's just no data to support the use of it.
Say nursing gives it?
Because in their policy and.
I think it's in the
procedure,
policy.
Is it that nursing can?
Hers, you remember?
It says we give it, right?
Is mucus?
I don't think it says we give, no, we don't give it.
Right, does it say nursing?
Yes.
That's what I thought.
But I mean,
Yeah, but these are airway
available
patients,
guidelines
like
for
trach
airway
patches,
clearance
so
do
we
not
have to
support
give
issues.
aerosolized medications to
So
airway
you-
patients. We argue with them all the time.
You asking for the data that supports their subscribing this? Because there is no data, as Dean has already suggested. You know, show me what your support for the use of this drug in this setting is, because there is none.
Where did you have it ordered recently?
The SICU,
Yeah, because these are Ellison 19 patients, and they're airway patients in there. Anyway,
I
we
argue
can talk
back.
about- Yeah,
I try.
I argue all the time.
All right,
okay, we can talk about that
Another day.
another time.
what about Dornase alpha, pulmazine? Sometimes I spell that wrong, but I think I got it spelled right this time. So this is effective only in cystic fibrosis. It does not have an indication other than cystic fibrosis. And it has been studied in COPD and patients with COPD in that big study who got pulmazine had worse outcomes. So it doesn't help in COPD, and it could make things worse for COPD. So the only indication for pulmazine is cystic fibrosis. What about hypertonic saline? It is effective. 7% is effective for cystic fibrosis. 3%, I don't know what the practice is here. A few years ago, there was a lot of interest in the literature in using 3% for bronchiolitis. The most recent literature that I have read shows that it is not effective. So is it still used here or not?
Bronchiolitis or bronchiectasis?
Bronchiolitis.
We've never used it for
The nurses
they
used to
don't
do the
use it.
teaching
We're not
as
using
to.
it anymore.
Yeah,
That's right.
because
It's not on the
Zero right
pathway.
now.
Yeah, the most, so there was, about 5 years ago, there were a whole bunch of studies about, not very well done studies, showing that it helps for bronchiolitis in children. And then subsequently, there were well done studies, randomized controlled trials that shows that it doesn't help.
So for
Yeah.
cystic fibrosis, are we getting orders for 3% on occasion? Or only 7?
I think sometimes 3.
Sometimes
Yeah.
3, that's what I thought when I was
For
up there.
bronchiectasis, for cystic
For cystic
fibrosis.
fibrosis.
Yeah, the studies were done on 7%, but some patients don't tolerate 7%. 3% is effective for induced sputum. Inhaled normal saline is not effective, so you can put that in the same bucket where you put the aerosolized mucus. Doesn't help. Okay, what about antimicrobials? So there are a number that we can talk about. So the first are the aminoglycosides, and the aminoglycosides do have an indication in patients with cystic fibrosis. Tobramycin, or Toby, is administered twice daily, as you know, on alternate months. Why on alternate months? 20 days on, 20 days on, 28 days on, because of resistance. So it's to try to avoid resistance. It's most commonly administered with a PARI nebulizer. It is available in a dry powder form. The dry powder form I don't think has ever caught on because it is the most complicated dry powder inhaler that you'll ever use. So patients probably need to have advanced degrees in order to figure out how to use the thing. It's certainly not as easy as a PARI nebulizer. Amikacin and gentamicin can be used, primarily in patients who are whose bugs are resistant to tobramycin. More about amikacin, I think, on the next slide, and it's not in your handouts because it's a brand new drug that was just released. Estrianam or Tasting can be used, so that's used 3 times a day with the Altera mesh nebulizer. That's what that looks like. I saw that there was one on Purvis's desk earlier, so if you don't know what that looks like, stop by and Purvis can show you one. What about antibiotics for VAP? Whole lot of question marks about that. What I can tell you was that there was a very large, like thousands of patients, very large, multi-center, multi-country study, looking at the use of inhaled amikacin in patients with gram-negative ventilator-associated pneumonias, and it did not work. The study was stopped. After millions of dollars of investment, the study was stopped about a year ago. So there are lots of questions about antibiotics for VAP. There are strong advocates who use them a lot. There are others who advocate very strongly that they should not be used. So I think that it's sort of clear where they stand. Not good evidence, I think, one way or the other. Amphotericin B lipid complex, or Abelset, is used in the prophylaxis of aspergillus following lung transplant. They're still using that. I know they're using that when I was around all the time. Ribavirin for severe RSV infection. Do you still have those battles from time to time? Or is that gone
No,
away?
we were talking about that. We can't remember the last time they actually used it. It's got to be 4 or 5 years ago.
I heard from someone, and maybe you know, that the company ICN is not even making the spags anymore. I don't know if that's true or not.
But
Somebody
don't know that.
told me that on my travels. And then
We wanted to throw away all of our stuff, but we're afraid that once we throw it away, we'll get an order.
yeah, you may not be able to get replacement parts. I had heard that they don't make it anymore. So
Well, that tells you its efficacy.
yeah. Well, and that it can be administered orally, and there are other ways.
Well, yeah, but by aerosol.
Yeah, than by aerosol. And then pentamidine, administered by the Respigard 2 nebulizer, can be used for prophylaxis of pneumocystis, what we used to call pneumocystis carini, administered once a month. There are better oral drugs, like Bactrim is what is typically used now for that. But there are some patients who can't take Bactrim and still take pentamidine, but it's very few.
Yeah, I mean,
We get maybe 2 a year.
I was going to say, I don't remember. We do get some orders for it.
Occasionally.
It's usually done on an outpatient basis.
Yeah, they do
you know,
it in
yeah.
They can go to the Cox 2, PF2.
But back in the mid-1980s, and Bob knows about this, back in the mid-1980s, during the HIV epidemic stuff, there were respiratory departments who had clinics where therapists just did pentamidine treatments essentially all day long, you know. So,
And there were numerous case studies of therapists having significant pulmonary issues as a result of
yeah, so that's
delivering.
the reason why the device, for example, has valves and filters and so forth to try to decrease
That chronic exposure is
the
not
chronic
good.
exposure. Yeah. So this is the new one, and then maybe we'll stop after this one, and I've got material for the next talk already prepared. So this is the latest one to be approved by the FDA. So this is amikacin liposome inhalation suspension. And so this is amikacin. It is used for specifically to treat, difficult to treat, MAC infection, Mycobacterium avium complex. So, I don't know, if you might do sputum and find out that the patient has MAC, and then you might be doing an aerosol treatment to treat that. This again is approved only to be used with this mesh nebulizer. So this device was approved specifically to be used with this drug.
Is it the same?
Pardon?
Is it the same one as?
So it is basically the same one as for Caiston. What I don't know is whether the mesh, so this is a mesh nebulizer, I think that the mesh is specific for each of the drugs.
It's a little different. So I don't think, I mean, Caiston is not on our formulary.
It's not. It comes from a
And I doubt
specialty
that this
pharmacy.
is on our formulary.
Correct. So the way that this is available and the way Caiston is available is patients, and this will, I think, be used primarily in CF as well, but patients get from a specialty pharmacy a 28-day supply. So they get a box. If you ever saw what comes with Caseton, there is a box that is about this big, and inside that box is the nebulizer and 28 days worth of the drug. And so every 28 days, so end of 28 days, use up all the medication, throw it away, and then get a new box. And this, I'm sure, will be the same way. Yeah, this is not something, your point's a good one, this is not something that is going to be on the formularies probably of any acute care hospital.
Correct.
And it needs to
Because
come,
it costs a fortune.
and it costs a fortune, it needs to come from a specialty pharmacy. So you can't go to CVS and get it either.
And it'll probably end up to be the same thing. We'll see it in select cystic fibrosis patients.
So this is reserved to be used in patients who have MAC or unresponsive to conventional therapy.
Treatment, right.
So it will be a very rare use. Okay, so we will stop. And the next
So
time we
before
will
you
talk
stop,
about vasodilators.
Give us a couple comments about tranexamic acid. Because we have just started to use that. 4 patients, 3 patients, 4 patients, somewhere in that, ballpark.
I only had one line about that.
Okay, so you know as much as we know
So
about
it's
it.
used to control bleeding in patients with non-massive hemoptysis. And there have been a couple of papers, one published just within the last couple of months in Chest
Yeah, we got
about
it.
this. So.
Right.
Being
It
questioned-
seems to work.
Yeah, it seems for a CF patient. And so we're looking to see what literature we can find. The pharmacy's approved it, but they just didn't check anything. So we're looking to see.
Was it the firm